my colleague, Dr. Joanna Katzman, who's the Senior Associate Director of ECHO, is going to be leading this initiative on behalf of ECHO. And I want to just take a minute to welcome you all. And secondly, invite you all to reach out to all your colleagues. And so because we're going to have this on a regular basis, and we're planning in the beginning, Joanna will, Dr. Katzman will tell you more about the details, so that our mission is to train every healthcare provider in New Mexico, all doctors, nurses, medical assistants, and anyone in your clinics who wants to be trained on COVID-19 from the perspective of a provider. They should join one of our sessions. The only other thing I want to mention is we have a very special guest on the call today, as Dr. David Scrace. Dr. David Scrace is the Cabinet Secretary for Health and Human Services for New Mexico. And he will open this meeting with a few with a few comments, after which Dr. Katzman, and give you a brief presentation, after which Dr. Katzman will tell you how we are going to engage over this time period. Thank you again all for joining.
Thanks, Dr. Aurora, and thank you everybody for being on this very important call today. Just a few announcements before we begin. Really glad you can join us today. We will be recording this session, and we will be having more of these sessions next week, so please definitely tell your fellow clinicians and healthcare workers that more sessions are to come. And with that, I'd like to again introduce Secretary David Scrace for the New Mexico Health Services Division. He's really been really leading the effort along with Governor Michelle Lujan Grisham. David Scrace will be presenting on an update on COVID-19 in New Mexico, social isolation precautions to slow the risk of transmission, and he'll also be presenting for Cabinet Secretary Kathy Kunkel on how to obtain necessary COVID-19 testing for your patient, wherever they may reside in New Mexico. So thank you so much, Secretary Scrace, and we're ready for your presentation.
I want to send you all greetings from Kathy Kunkel, who is the Secretary of Health. I'm kind of deputized by her to help her, and it's just no longer possible for us to be in the same place at the same time, given all the different things that are going on in our state right now. If we go to the next slide, you can see that COVID-19 is rapidly spreading across the entire world. It rapidly is a main part of it. Most diseases, like influenza, you may become infected and become symptomatic in 2 days and infect others. COVID is more like 5 to 7 days, and there's a debate about whether it's infectious before you're symptomatic. I think the experts at UNM in infectious disease believe it is. But this is growing rapidly, and you can see in the Americas a rapid growth of cases. Next slide. In the United States, and unfortunately this slide is way out of date because we only got it yesterday, but I do actually encourage everyone to put the New Mexico Department of Health website, cp.nmhealth.org, on your desktop. I start every day with that, and then you can also go from the DOH. You can see how many cases are in New Mexico, and then you can move to this slide, which shows you throughout the country. I can't demonstrate it, but if you hover over states, it will also tell you whether there is community spread present or not in those states. And so it gives you a chance to look around the country, see what's going on. An example of why this is out of date is you can see West Virginia shows no cases when we acquired this map, but now they do have cases. Next slide. Right now, this is the website I said to bookmark. These are the symptoms that we tend to focus on. These are the numbers out of China. But when we do our messaging, we talk about fever, cough, and shortness of breath, just because fatigue is not the most prominent symptom, and fatigue alone is not really predictive of a COVID infection. Next slide. I wanted to mention something, and if you read our little op-ed in the paper, you already know this, but in 1918, Gunnison, Colorado, actually blocked off their town at both ends of the single street that ran through it. They made everyone stay inside. They put people in jail that they caught outside. It was the most potent and distinctive social isolation experiment during a pandemic ever, and they had no cases at all. And so I'm going to talk a little bit about flattening the curve. If you go to the next slide. There is a little bit of, I think I moved the slides around, but I can work with this order. What I mainly want to emphasize is New Mexico has acted very quickly. We declared a public health emergency on the day that our first case was reported, and that makes a big difference. It gives us time. The epidemic tends to reach its peak after 4 to 6 weeks, and so we really still have, that minus 8 days to prepare. And so that's a good thing for New Mexico. Next slide. And this is the curve I wanted to talk about. If you see that the curve on the left has a tail there, but then it rapidly rises. And that's the level of infection we would expect in our state with no immediate state interventions to promote social distancing. And you can see that dotted line there is the capacity of the delivery system. And so very, very quickly it is overwhelmed, and we get into a situation like if you're watching the news, they have in Italy. So most of the seemingly draconian measures that have been announced by Secretary Kunkel are designed to move us to that flatter curve. We want New Mexico to be that lower curve that doesn't overwhelm the delivery system. And so we're sending out a lot of messages to really encourage providers to not see patients with respiratory infections in their offices, patients not to go to ERs or offices, but coming up with other ways. And so you can see the list of things that we've already done. And we think we're now, today or tomorrow, into that range of where we expect to see more overt community spread. Community spread is when you have a patient who doesn't really know how they got the infection. Up till now, almost every single case has been travel related, a family member of somebody who traveled to a hotspot like New York City. We have folks from the cruise ship and the like, but now we're starting to see cases, and we think in the next day or two we'll know if we have more random spread cases. Next slide. Case fatality rates vary by age, and you can see here, if you look at the curve on the right, that there's a dramatic increase in mortality rate in older people. As a geriatrician, I think the one intervention that I would recommend for my patients is to stay indoors. Don't open the door for things. Let your neighbors leave your groceries on the front porch and go out and get them. But I would actually recommend for most seniors that they shelter in place, which, if you don't know, Santa Clara County recently required of everyone in San Francisco just a day or two ago. Next slide is what we're asking people to do is stay at home, avoid mass gatherings, anything over 10. We've closed schools, libraries, museums, and eateries. We've limited public transportation, and individuals with mild and asymptomatic infections are being isolated. And so that is our current approach. Last night, or yesterday, the governor was even more specific about what that meant. And we think it is our chance to flatten the curve, and we're hoping that all New Mexicans will comply. I got asked by a reporter, can you describe the best case and worst case scenario for our listeners? And I said, no, I can't, because we just don't know what it's going to look like at either end of the spectrum. But we do know for a fact that the thing that'll make the difference between the worst case and best case scenario is the behavior of the people in New Mexico going along with and self-imposing that social distancing that's required to reduce spread. Next slide, please. There's some other things here. I'm not going to go through them. There is a blood shortage. because people are afraid of donating blood. So all the providers on this call, please encourage your patients to consider donating blood. We're working with blood banks to have a drive-up way of doing that, so you don't have to sit in a waiting room with people, and can easily continue to maintain your social distancing while you're donating blood. Excuse me. And then that was allergies, not COVID-19. So you can see a list of things here. Next slide. Keep going, because I'm doing both presentations. Keep going. So if you go to NewMexicoHealth.org, cv.nm, you can see that there. Clinicians, you can get guidance regarding clinical care, infection control, and PPE. If you're short of PPE, call the number on the screen. There's also COVID testing kits, which are not really testing kits. They're specimen acquisition kits. Typically, they consist of a plastic bag, a swab, viral transport media, and a label to put the patient's name on, to put on the viral transport media. Next slide. New Mexico is actually doing amazingly well in testing per capita after this was through March 17th, after 7 days. We'd actually had more testing per million people per day than anybody, state, country, whatever. We're off to a great start in testing, but obviously clarification is needed, and Kathy wanted me to convey this information to all of you. Next slide. Next slide after that, it says the same thing. So treating symptomatic patients, there's 3 or 4 steps to that. The first step is really, and I'm going to talk about them like 3, because 1 is optional. Everybody needs a risk evaluation. Some systems are doing this by computer. You can print out the risk evaluation form from the DOH website and have your receptionist ask the questions. They don't require a lot of clinical sophistication. They mainly focus on travel history, symptoms, and any medical history. You know, there are some high-risk groups. And then arrangements are made for the patient to go to a testing site, and I'll talk about that in a minute, to get a sample, or everybody can do this outside your office in the parking lot. It does require a surgical mask and a face shield and a gown and gloves. And then the testing itself, and there's a lot of confusion about this in the state. The testing occurs in a reference lab. Currently, Tricor and the state lab are doing these tests. And also we know that other labs have limited capacity. Quest and LabCorp in the southern part of the state are doing some tests as well. Next slide, please. These are the testing criteria. These are important. I would love to talk for the rest of the hour on the top line, which says if you're asymptomatic, testing is not required. If you're asymptomatic and really, really worried and calling your doctor 6 times a day, testing is not required. So, and we all have folks like that who are very anxious and just want to get the test. But the trouble is, if you're asymptomatic and you get a test and it's negative, why, by that logic, why wouldn't you get a test the next day and the next day and the next day? And we're trying to preserve the materials for testing. So we want these to be particularly applicable. And then if you have symptoms of acute respiratory infection and you've either traveled to a hot spot, which consists of Europe, Iran, China, Japan, and South Korea, which changes every day, or places in the United States, which I think include California, New York City, Seattle, and Chicago, then you would be a candidate for testing if you're symptomatic. If you don't have any of those risk factors, and now we're back up to the second row, but you do have an infection, then you would go ahead and use your own clinical judgment. If someone's desperately short of breath, then, needs oxygen and is blue, then of course you call 911 and send them to the ER. There are other risk factors here on the slide I won't read. Next slide. There are COVID sites coming up every day. I'm working with staff over at DOH to get those up and running. And so hopefully There's one starting in Doniana that'll be open tomorrow, and then another one on Monday. I think they're at Memorial Hospital on Friday and Burrell College on Monday. And you can see other ones. The green ones are ones that are already up and available, and the yellow ones are ones the DOH is working on getting up. But again, please look at the DOH website because it will be updated there every day. Next slide. This just goes over the labs. I've already done this. We think it's best for patients to talk or call their primary care office. And we'd love it if providers would refer them to a testing site for testing, unless you prefer to do it in the parking lot of your office and you have the appropriate PPE. Either one is fine. I've already taken specimens from people myself, but you don't want to bring them into the office. So I would like to lead a revolution in New Mexico healthcare where we don't use waiting rooms at all for the next period of time until this epidemic is over, and then maybe a month or two after that. And so be creative, figure out how a patient, for example, could drive up, give you a call, register over the phone. Maybe someone that comes out to the car and grabs some information, maybe not. If they're not sick, you might do that differently than if they are sick. And then could be preferably called into a waiting, called and brought right into the exam room. Also, we know that some places like grocery stores are reserving time at the beginning of the day to see elderly patients. And so we would recommend that you all think about that as well. Is there a way to shuffle your schedules and bring your older patients in at the beginning of the day, where they're older non-sick patients for maintenance visits, so they don't come in contact with acutely ill people later in the day? Next slide. Chris is saying, you can see these drive-through sites. Presbyterian has a couple open. Presbyterian uses a referral method where you fill out something online. St. Vincent also would like a physician's referral. And then there have been drive-throughs. Lovelace ran one last week, and they're opening, I think, again tomorrow for that as well. Next. But we don't want everyone to get a test, and particularly, again, asymptomatic people with no risk factors asymptomatic people don't need testing, period. More of the test sites here. You can see those there, and DOH, as I mentioned, is offering testing in Roswell, Las Cruces, Socorro, and Las Vegas very soon. Next slide. So let's just talk about these two cases. These are true cases. I get a text message about every 10 minutes about someone who knows someone who knows someone who was COVID positive. And in tracking down as many of these as I can with the help of the Department of Health, the main thing that's wrong with all the stories is the person that they thought was COVID positive is not. So again, you don't need testing unless you're symptomatic. So case one, Alex interacted with a customer who recently traveled out of the country and was sick and coughing. The customer returned to the store 2 days later, and then Alex, the worker at the store, started feeling symptoms that same day, followed by chills and lung pains. Then she had a sore throat, muscle aches, waking up at night, and dyspnea. She was negative for influenza, and she's asthmatic. So what would you do? Sorry we don't have voting today, but you could send her to the ER, and I'll just walk through these. You could have her come to your office, wait in the vehicle, do a screening evaluation, and then do a nasopharyngeal swab and send it to the lab. You could send Alex to a COVID-19 testing site, or you could do nothing. And really the only absolutely wrong answer is A. You could do B, you could do C, or you could decide on your clinical assessment that this is probably not COVID, given that she became symptomatic 2 days after seeing a patient. Usually it's 5 to 7 days, and you could have her go home and self-isolate. I think Alex will want to test, but you have that option under B and C. And just one more case, we go to the next one. Kellen, 76-year-old male, temperature of 101, dry cough, mild shortness of breath, just came back on a plane from New York City and is self-isolating at home. Doesn't think he ran into contact with anybody who was COVID positive, but he said there sure were a lot of people coughing on the plane. So the same choices, again, his shortness of breath is only mild, so he doesn't need to go to the emergency room. you could have him come to the office and sample him in the parking lot, not in the office itself, or you could send him to a testing site. And I think I certainly wouldn't opt for D, given that now he's pretty symptomatic and he has that fever. So I think B and C would be the best options. And I think we might be done. So is there another slide? Yeah, that's it. So we probably don't have time for questions and comments, but I'll refer back. I know we had 20 minutes. So Sanjeev all right, good.
I'd like to introduce Dr. Megan Brett now. Dr. Brett is the hospital epidemiologist for the University of New Mexico Hospital. She is a professor in the Department of Internal Medicine in Infectious Disease Division. She also runs our antimicrobial stewardship ECHO, and she's going to be talking today on COVID-19 epidemiology and infection control. Thank you so much, Dr. Brett. We're looking forward to you speaking.
Hi, good afternoon, everybody. Again, this is Dr. Megan Brett. I'm one of the infectious diseases physicians here at UNMH, and I'm also the hospital epidemiologist. And this has been a very busy and popular time for anybody in infectious diseases. So what I'm going to do is actually mainly focus on infection control, because I think that's a huge issue here and everywhere in offices, in hospitals, and everywhere else that individuals with coronavirus infection may show up. So I just wanted to talk through some principles that I think are important and say that this is the latest up-to-date information that I have, knowing that this could change in a week. So again, I'll just share what I've learned so far and what we're kind of guiding people here and here at UNMH in addition to beyond as well. So could you advance the slide? All right, so I think one of the questions that's existed is about whether COVID is actually a droplet or airborne infection. And what I would say is droplet means that you're within 3 to 6 feet of someone. What I'll say is that SARS the first, because coronavirus is SARS the second, is that SARS the first was actually probably predominantly droplet transmitted. That means, again, that you had to be within 3 to 6 feet of an individual. What I would say, though, is there are things that can cause this infection to become airborne. And what I'll do is kind of review some of that in the next few slides. So again, I think social distancing is going to work if we do stay 6 feet from each other. I think that will be incredibly effective to help the spread of infection. So I think, advance the slide if you would. That I think, so coronavirus is actually probably somewhere in between, and I think it really depends on what you're doing with patients as to whether or not it's more of a droplet or airborne spread. Next. So the other key thing to know is that contact transmission is still important. I don't think that's the most critical thing, but it's still something to consider, and that would be in conjunction with droplet or airborne. So next slide. I think taking into mind that this is predominantly a droplet transmitted infection and that it can be on surfaces, again, still not clear for how long. It depends on the surface type. It depends on the load. It depends on what the humidity is. The point is that I think thinking about making sure that people are protected depending on what activities you're doing with patients is key. So what I would say is, for example, here at UNMH, when we have screening of visitors or people entering the building, we're saying that those individuals generally need to wear surgical masks, eye protection, they need to perform hand hygiene regularly and high touch cleaning. The other thing you could add is certainly working on that whole concept of not touching your face, which is incredibly challenging, such an automatic behavior. For routine care as an inpatient, what we're working towards, and we're not there yet, but we'll be moving more towards surgical masks, eye protection, gloves and gowns, hand hygiene, and high touch cleaning. Again, you can see that certain themes are going to be contiguous throughout. And last but not least is for the times when there may be aerosols, that then we're going to ask people to wear N95s. At that point in time with either cappers or pappers. So again, those are the positive air pressure helmets that people wear. in addition to gowns and gloves, and then performing hand hygiene and high touch cleaning. What I'll say is that this is aligned with what the World Health Organization, CDC, and has been done at the University of Washington. I'll just mention that that is actually a great site for protocols and other tools that have been developed, since they are way ahead of us on the curve. So I would urge people to take a look at that site, because I think that has incredibly useful information. So next slide. So when do you actually need airborne protection? And what I mean by that would be making sure that people are wearing N95 masks, and in particular in the hospital, when do people actually need to be in airborne isolation rooms? What I would say is that would be if people are being intubated, if people are being given nebulizer treatments. So I would say even in the outpatient setting, that's something to be considered, is that actually can lead to aerosols. So if you've been using nebulizers, then I would say now is a good time to potentially consider switching to things like meter dose inhalers instead. If you notice that a patient is coughing and sneezing a lot, a little bit more protection for you or other healthcare workers is a good idea in terms of wearing a N95 at that point. More non-invasive ventilation. And I know the other guidance at the moment is that nasopharyngeal swabbing, at times, it often needs to be done with an N95 mask. That's probably not from the procedure itself. It's more due to the risk of causing someone to cough or sneeze after inserting and then pulling out the nasopharyngeal swab. So those are all things that can potentially lead to aerosols. And that's when I think a higher level of protection would need to be considered to keep staff safe as well. What I'll say just about the nasopharyngeal swabbing is CDC's current guidance is that you have somebody obtain the swab in a regular room, but with PPE that includes an N95. Again, that's for high-risk individuals. So that at the moment would be anybody that's traveled outside of New Mexico or has a close contact with someone that has known coronavirus infection. So that may not need to be done for everybody until there's more evidence potentially for ongoing community spread. All right, next slide. So I think some of the challenges for infection control during this time period, both in hospitals and clinics, are the fact that screening by risk is going to be something that potentially changes. So stay tuned to the Department of Health information. The challenge of having asymptomatic individuals who perhaps have higher viral loads than symptomatic individuals is also going to be challenging. And so that's where I think thinking about how we, again, continue to protect those in healthcare is an important consideration. And again, kind of along those lines, what we can do to keep ourselves safe while working. I also think the issue of presenteeism by healthcare workers, meaning that we continue to come to work while sick, is something that really needs to be considered. And again, encouraging people, if they are sick, to stay home. And I think things like testing is particularly in the hospital, to make sure that we optimize our use of personal protective equipment is incredibly challenging at the moment too, to make sure that we get the tests back sooner so we can take people off of isolation. Again, some of the major countermeasures are principles that work for flu in addition to coronavirus. That would be things like hand hygiene, increased consciousness about taking off PPE, and again, potentially consider doing that with a buddy to make sure that you don't self-contaminate, and doing things like high-touch cleaning. I think that's actually pretty effective for reducing the spread of many different infections, not just coronavirus infection. So that is my 2 cents about infection control and infection transmission as it relates to coronavirus.
Thank you, everybody. Thanks, Dr. Brett, so much. That was a fantastic presentation. We so appreciate that. If you could stay around for about 15 more minutes, we have lots of questions coming in the chat that are fantastic. I think we're going to move on right now to Dr. David Rakel's talk. David Rakel is the professor and chair in the Department of Family and Community Medicine here at the University of New Mexico School of Medicine. We're so fortunate to have him be speaking today on how to best perform telephone triage for possible COVID-19 patients. This is so extraordinarily different from most clinical conditions when patients are told to go to the doctor, go to the urgent care, go to the emergency room when they have signs or symptoms of clinical problems or infection. And in this case, where patients are being told not to come in. So Dr. Rakel is going to address how to perform kind of optimal telephone triage in this time of COVID-19. Dr. Rakel, are you on?
Yes. Can you hear me?
We can hear you and we can see you. Thank you so much.
All right. Well, thanks. It's an honor to work with Dr. Brett and Dr. Scrace. I think New Mexico is in good hands with their leadership, and my perspective mainly comes from an outpatient one. And so this is one of my favorite quotes by Louis Pasteur, the father of germ theory. And obviously in this condition, it's both. It's the microbe and the terrain. But even more importantly is how do we look at the terrain of our patients and make sure that we realize that that's the main clinical determination, is how sick our patients are, because it's the oldest and the most vulnerable that we have to be most aware of. So I'm going to go through these pretty quickly because Dr. Brett and Dr. Scrace both covered a lot of the screening, and that's my next slide. And you know, in primary care, we're all used to seeing viral syndrome, and this is no different. I think the main thing is this can also have some GI side effects like nausea, sorry, not side effects, but symptoms of nausea and diarrhea, sore throat, and headache. But it's really the bread and butter upper viral syndrome with fever. 99% of folks have fever. Next slide. This comes from the director of the WHO, and this really is determined on how many kits we have. If we had unlimited kits, we'd test everybody because there's a majority of people who are asymptomatic. So if that asymptomatic person goes home to their elderly grandmother, we obviously would not want them to be in close contact. But the reality is that we do have limited test kits, so we are going to focus our surveillance on those at highest risk, which is the next slide. And that's elderly, lung disease, heart disease, diabetes, and immunocompromised. So, and then next slide. So let's say someone's at home and they're on home isolation. When would we have them come into the hospital? And this is really pretty much common sense. The thing that will make someone at most risk is their pulmonary status. And as this virus causes fluid to leak into the lungs, if someone's shortness of breath is gradually worsening, they need to come in. And if they have multiple comorbid diseases, they need to come in. And the sooner we can have them in a safe place where they could be escalated up to triage to, hopefully not, but a ventilator, ultimately, it's the host and the quality of the resistance of the host that should really guide our decision making. So that's a lot of common sense in primary care. You know your patients the best, and you know who's going to be most at risk. And having that relationship with your patients is really one of the best diagnostic ingredients we have. Next. This is when we might remove someone from home isolation. And I think we're probably going to get to this point. And this really depends on how many test kits we have. If we have plenty of test kits, and this first one also I think is really relevant for medical personnel who we need to get back in action. So if I have one of our residents, for example, who's on 14 days of quarantine, and we have a tremendous need in the hospital for them to come to work, we have this guidance now from the CDC. If they don't have a fever and their upper respiratory symptoms are improving, and they have 2 negative tests 24 hours apart, then they can be removed from isolation. Next slide. And if there's not enough test kits, then there's the timing. They need to have 3 days free of symptoms, no fever, cough, or shortness of breath, or 7 days from the first symptom. And this is from the CDC that was published 2 days ago on the 16th. Now, another thing that we'll do in primary care is how can we engage or empower someone who might have COVID, who's at home, isolated, otherwise pretty healthy. And that brings us to the next slide. These are things that we can do to support any human's immune system. And obviously hydration is a big one. I like green tea too, because the green tea leaf has polyphenols. Polyphenols are really good for the immune state, but water, 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 and hydration. Next. You know, this is a challenge. One of the biggest hits on the immune system is social isolation. So if we're physically isolated, doesn't mean we need to be emotionally isolated. So how can we make sure that we're connecting with people in face-to-face ways so they know they're being cared for and thought of? Next. And then we all know that when we have our sympathetic overdrive, our immune system goes down. When we have our parasympathetic system activated, our immune system improves. And if you look at any stress-reducing app on your phone that wants you to relax, it will slow your breathing rate down to 6 breaths per minute. 6 breaths per minute is a magic respiratory rate where your baroreceptor stimulates the parasympathetic system the most. So if we're all stressed during this time, slow your breathing rate down to 6 breaths per minute. That will maximally stimulate your parasympathetic nervous system and your immune function. And while you're at it, doing that slow, deep breathing, do some imagery. Next. And this is one of my favorite studies. Most of the research has been done in college students, and these were healthy college students right around testing. And they had the college students imagine that their white blood cells were ping pong balls covered with honey. And then they looked at the agglutination of their white blood cells, and just with imagery, their agglutinization, the ability of the white blood cells to clump onto a bacteria actually increased. So what's the harm of that? And it's empowering. So encourage your patients maybe to use a little imagery. Next. This is my favorite supplement of all time because it seems to work for a lot of things. N-acetylcysteine is mucomist. And if you remember, we use mucomist a lot in our cystic fibrosis patients to clear their respiratory secretions. And so that's what is the main symptom. And remember, we don't have any evidence on this for COVID. We don't really have much evidence on anything for COVID because it's so new. But if I was going to look at how this benefits other things, and if I was going to choose one supplement that I thought might work for this, I would choose N-acetylcysteine. We also give N-acetylcysteine to prevent contrast dye nephropathy when we put people through CT scans. We also use N-acetylcysteine for Tylenol overdose in kids because it increases glutathione, which is the strongest antioxidant in the body. We want a lot of glutathione. The liver is also a really strong immune organ. And there's some promising research on N-acetylcysteine for influenza. This is over the counter, 600 milligrams twice a day. The potential risks are quite low. Next. And lastly, zinc. I tell our family medicine residents, ACE to zinc, because if you have an elderly patient on an ACE inhibitors lower zinc. And zinc is one of the most important minerals for our immune function. So if someone's on an ACE inhibitor, consider, and they have COVID, consider supplementing with a little zinc. Now, you may have also seen in the literature that COVID causes fluid accumulation in lungs through the ACE2 receptor. So there's this discussion on whether we should stop ACEs or give ACEs or ARBs with COVID. And I just looked it up to see what's changed in the last hour. And the evidence continues to say we don't know. So we're not saying stop or start ACE inhibitors. If someone has COVID, maybe tomorrow that will change. But if someone, particularly an elderly, is on an ACE inhibitor, it's likely that their zinc level may be a little low. So giving them a little zinc boost may help support their immunity. So that's all I got for today. Thank you.
I'd like to now introduce Dr. Michelle Harkins, who's a professor in the Department of Internal Medicine, who's a pulmonologist as well, and leads the Division of Pulmonary, Critical Care, and Sleep Medicine here at the University of New Mexico School of Medicine. We're so happy Michelle could come on and talk about the treatment of COVID-19 in the hospitalized patient. Thank you, Dr. Harkins, who's here with us in the room here.
Thank you very much for the invitation. Next slide. And some of you have seen this obviously before, and again, the common symptoms are fever, dry cough, shortness of breath. Those are the most common. There are other that are less common, some GI comments, as Dr. Rakel meant. earlier, headaches, and so we see commonly fever, shortness of breath, and dry cough, but there are other flu-like illness symptoms that can occur with these patients. Next slide. These are some of the laboratory findings for patients with this disease. Interestingly, the white blood cell count is usually normal, and in fact has low lymphocytes if you get a differential on the white blood cell count. There may be some mild thrombocytopenia, though this is not 100%. Many of the patients may have some mild hypoxemia. They may have a metabolic acidosis. They may have elevated liver function tests, elevated liver dehydrogenase enzymes. They have high CRP. So CRP is a C-reactive protein, which is an inflammatory molecule, so that may be elevated. They may have elevated CK levels or creatinine kinase levels, which are muscle enzymes. Also a normal procalcitonin. So procalcitonin is being used in the hospitalized setting and in the ICU to assess if there's a bacterial infection. So typically we think an elevated procalcitonin level may suggest a bacterial infection. So these patients have viral infections, and so usually the procalcitonin is normal. D-dimer is another laboratory test that we're looking at in the patients in the Wuhan series in China. Those that had worse outcomes had a very elevated D-dimer level. This is a test that I'm not suggesting that you get all of these tests on the routine patient, but in a hospitalized patient, it may help you to predict potential worse outcome or the risk for worse outcome. Liver function tests are elevated in about a third of the patients in the Chinese series, and several had low PTT or other coagulation tests. So they were low in about 30%. And there's variable glycemic control. So you could have a variety of things happening in your glucose levels. So these are just the typical findings from the Wuhan series in China. And we are noting that that's seen around in our country as well. Next slide. The early stage case fatality rates in China were basically the patients that had these underlying health conditions. So cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. And so patients that have these as comorbid conditions are at the higher risk for having more serious disease if they do contract this. If they had no health conditions, about 0.9% of those patients really didn't have did not have a risk for death. But that is why we're stratifying patients to have people that have coronary disease, diabetes, chronic respiratory problems, hypertension, and cancer as an increased risk of a worse outcome from this disorder. Next slide. This is a little simple clinical pearls cheat sheet that one of my colleagues put together. And I'll have one later that's a little bit more for the intensive care patient. But the incubation period, as mentioned, range of 2 to 14 days, but typically 5 to 7. The 3 most common symptoms and the common laboratory findings that we've just discussed. Chest x-ray findings and radiographic findings on CAT scan. So ground glass opacities on the CAT scan, that's what those little arrows are pointing to. They're basically white patches on the CAT scan. And you may have ground glass or increased interstitial markings on a chest x-ray for patients that have this disease. Most of the patients in the case series that I have reviewed have had abnormal chest x-rays, and many have had floridly abnormal CAT scans, but some may have simple ground glass opacities, such as seen on this image currently. The patterns of disease, fortunately, 80% of patients have a really mild respiratory infection. Now, I'm not talking about the asymptomatic carriers, because I don't really know that we have the full base of what happens with everyone that does have the disease, but the majority of patients are going to have really mild disease, which is great. There is a non-life-threatening pneumonia that occurs in about 14%, and then severe pneumonia and ARDS about 5% in the China series. And that's very similar to what we're seeing here in the US as well. So the majority of the cases, they're going to have mild upper respiratory symptoms, and then only about 20% were hospitalized, and about 5% of those needed the ICU, such as mechanical ventilation and other aggressive therapies. Again, we mentioned the risk factors for severe disease, so age and all of the comorbidities that we previously discussed. Next slide. So I just have guiding principles because this changes on a daily basis, an hour basis, but use your good clinical judgment for who stays at home, who gets admitted to the ward, or who may need to be admitted to the ICU. You want to consider the risk factors such as age, comorbid conditions, and the disease severity if you have interaction with these patients as to who you're going to admit and where. If you do admit them into the hospital and into the ICU setting, I would recommend judicious fluid. They are going to be dehydrated initially, but I would give fluids, but judiciously, because at the end spectrum, some patients develop severe capillary leak, and so all of the fluid that you give them will worsen their pulmonary status. As a pulmonologist, we usually say when you're sick in the ICU, a dry lung is a happy lung. So that's not to contradict what Dr. Rakel said, but when you're really sick in the hospital or in the ICU setting, you don't want to have just fluid rates going at 100, 200 an hour just because. So you want to use fluids judiciously. You want to provide oxygen judiciously. These patients are droplet and airborne isolation, as Dr. Brett mentioned. You want to make sure you have appropriate PPE for providers and have a buddy. So have someone make sure that your PPE is on correctly, but before you enter a room. But more importantly, make sure that you have the buddy to watch you take your PPE off so you don't self-contaminate yourself. You want to watch for superinfection and clinical worsening. The patients that were admitted with this disease, especially in the more sick hospitalized population and the ICU population, had a clinical worsening in some patients. So they would get better, and then about a week to 10 days into it, have a surge or a worsening, in fact, have a cardiomyopathy. So we have seen patients that had normal heart function initially, and then as they progressed, some had a markedly decreased cardiac output and cardiac function based on likely the cytokine surge or their TNF, IL-6, other things that surge up and then cause the overwhelming sepsis that you may see, and then the worsening. Limit aerosolizing procedures. This you can do in your clinic as well as in the hospital setting. One of the things we've been talking about at UNM is for the respiratory therapist to use MDIs with spacers for the patients rather than NEDs to not generate aerosols. 4 to 6 puffs of an albuterol MDI equals the amount typically given for a nebulized treatment of albuterol. And so trying to use that, especially in your patients that you are very concerned that have this disease. We don't also want to use BiPAP necessarily. So just a face mask to treat hypoxia that has an exhalation port that's actually open to the atmosphere. So we try to avoid BiPAP, and we try to avoid really high flow oxygen. We have high flow nasal cannula, which can run at 100% and 60, 70 liters. That may generate more aerosol. So what we are really looking to do is actually to intubate early. If you have a hospitalized patient that is rapidly deteriorating, you don't want to wait to that rapid deterioration. You want to take a step back and say, well, maybe this patient is developing a worsening bilateral pneumonia with ARDS. I want to go ahead and do an intubation and put them on a ventilator. Instead of what we would normally do is just crank up the oxygen, then put them on BiPAP and try to avoid intubation. And so that's a different mindset for me to be in, taking care of these patients, that you want to intubate early so that you don't then shed the aerosol and expose a lot of other patients and caregivers to this disease. Supportive care really is still the mainstay. There was an article that just came out in British Medical Journal saying avoid NSAIDs. So avoiding ibuprofen in treating the fever component and rather using acetaminophen is our recommendation currently. If you do have an ICU setting and you're on a ventilator, we use lung protective ventilation for those needing it. We use paralytics, we will prone people, and we will be initiating a critical care echo shortly to go through how to take care of these patients in the ICU setting or even in the hospitalized setting to help our partners. Next slide, please. So this is just the intubation algorithm. And so you really want to save your PPE and your N95 mask for when you are using and doing procedures that are generating aerosols. That's why we've switched to mostly MDIs. We limit the number of people in the room with the patient. Our algorithm at UNMH will be one provider sees these patients for a period of time to try to decrease the number of patients, patient exposures to the healthcare providers. Next slide. But there are several other things you may be seeing in the newspaper, reading. There are a lot of other therapies that are being suggested, but there is not enough data currently to recommend routine usage on any of these. So chloroquine and hydroxychloroquine have gotten the most attention. Hydroxychloroquine has more potent activity against the virus in vitro, but we don't really know what to do for the inpatient setting right now. Tocilizumab is Actemra. This is an IL-6 inhibitor, and it is has a very strong IL-6 is a very strong role potentially, so if you block that, that's the theory behind using that. Vitamin C high dose, there are studies looking at that. The Calitra study, the two retrovirals, the New England Journal just last night came out with the article suggesting that these actually did not work in a randomized controlled trial. Remdesivir is in vitro and it can be in compassionate use. Corticosteroids may actually increase the risk of infection, so I'm not recommending it right off the bat for patients that are hospitalized. And this is a stay tuned kind of moment because we need clinical trials to really tell us what to do and what's going to be effective in certain patients or not. So these are just some of the things that are thrown out there. I'm not recommending routine use of these as of yet. The infectious disease department at UNM, as well as critical care, are having a task force to kind of come up with what our recommended protocol will be for hospitalized patients, and more will be coming. Next slide. This is also the Seattle Intensivist one-pager. So this has a little bit of everything on there as far as the biology of the virus, the epidemiology of the virus, flattening the curve, and we're talking about, the symptoms, again, the labs in the middle, and then the x-rays, and then again on the side, the different treatment algorithms. And that is really all I have to say, I think. These are additional resources.
Dr. Harkins, thank you so much. That was fantastic. I think all the talks were fantastic and extremely complimentary. I am so happy with everybody, and thank you everyone who's been on the call and been so attentive.